Okay, so recently we are recruiting new joinees in our hospital. So new candidates are coming for fellowship also. So we used to take interviews for them, and some few basic questions we asked them. So what I felt that though they know about the diseases in general, but when we ask the crucial points regarding from intensive care unit ICU point of view, because they are fresh candidates or they have not exposure of the ICU, some of the crucial points they are not able to stress upon. So me, Dr. Benjamin and Dr. Abhi from the East Committee of EHB ICM were sitting on this topic today morning on the tea, and we thought that why not make a video in which we discuss the common conditions of the patient which get admitted in the ICU and the key components, what to monitor, what to look for, so that it can be helpful not only for these fresh residents but also in the peripheries or even in the rural areas or wherever those who are working in the ICU, so they can know what things to be stressed upon when they encounter a particular condition. So this is not an exhaustive list, but these are 15-20 conditions which are very commonly encountered in the ICU. And I'm thankful to Dr. Abhi and Dr. Benjamin who have prepared this document. They are sitting behind the camera also. So in case I miss them, they will prompt in between. So the structure of this video will be, I'll be discussing the certain condition which are the common condition and the key components which you want to look for, and then you can go and read more about it. And when you are handling such patients in the emergency or the ICUs, these are the crucial points which as a new resident or senior resident or the consultant are interested in. So first is respiratory system. So in respiratory system, the common conditions which presents is COPD exacerbations and status asthmaticus. These are the patients who are known COPD or known asthmatics. Now they, because of any infection or any allergic component, they get exacerbated and they present with respiratory distress. Obviously there is a severe bronchospasm like that condition, and you start with all the bronchodilator, everything. Now what too important is, everybody is concerned, most of the new joinees are concerned with the SpO2 level or what is the PO2 in the ABG. But you need to look for what is the cost of breathing for that, maintaining that PO2. Like suppose saturation is 92, 93. But if a patient is having a respiratory rate of 20 for the same, and one is having a respiratory rate of 35. So obviously 35 is a tachypneic per patient, and to maintain the saturation, the patient is putting a lot of effort. So what are the possibilities? Slowly, this patient is on the verge of getting fatigue. So how will you pick that? You will pick that this fatigability by seeing the patient. He will becoming drowsy, and will start retaining PCO2. So other than all the things, all the bronchodilator or NIV or anything, you need to see whether this patient is clinically alert or clinically becoming drowsy. If it is becoming drowsy, it's an indication this patient is getting fatigue. Do an ABG, and even in the normal PCO2 in such patient, tachypneic patients, this is alarming. So this is indication this patient may require elective intubation immediately. So don't look just for the SpO2, look for the respiratory rate in such patient, and also more concern on the PCO2 and the clinical conscious level in such patients. So if a COPD exacerbation patient or status asthmatic patient started becoming drowsy, even though maintaining the saturation, or the PCO2 is rising in the ABG, this is an indication this patient is deteriorating and may require elective intubation. So this is something which you need to look for. Now the other thing which in respiratory system is pulmonary embolism. Now pulmonary embolism, as you know, embolism means it comes from somewhere else in the body. Most common site is deep vein thrombosis. So this patient presents with, there is unilateral swelling in one limb, and now patient is becoming dyspneic, and they present, and you know that this is pulmonary embolism. So you get an echo done and CT pulmonary angio, that are different. But what is important is not only saturation, most important is hemodynamically stability or instability. The reason is hemodynamically unstable patients are the candidates in which you need to thrombolize such patients. You need to deal with the thrombus, either systemic or locally. That is a different story, but usually most common is systemic. So So P is pulmonary embolism is defined into T classes: mild, moderate, severe. So in what happens, there is a thrombus which goes from right ventricle and gets stuck into the pulmonary artery, and then it causes desaturation. So in mild cases, there is thrombus in the pulmonary artery, but when you do an echo, there will be no rise in pulmonary artery pressures, there will be no rise in troponin, and patient is hemodynamically stable. Okay, so you manage with your molecular weight or heparin like that. Moderate means there is a thrombus, but it is causing right ventricular afterload effect. So RV can have a PA pressure increased PA pressures, or the troponin is increased because of the right heart failure, but still the patient is hemodynamically stable, even though patient saturation may be plus minus. But in severe, along with all this, the patient's blood pressure is falling, the patient is developing shock, and the patient is requiring of vasopressor support. So in the third category, if the BP is falling, this is a strong indication to thrombolize this patient. Otherwise, this patient will collapse very fast. So in pulmonary embolism, not only SpO2, hemodynamic stability or instability is more important, and you should always live. So whenever you call a consultant, you can say that the blood pressure is fine, saturation is so and so, and so he will is sure that you are looking at the right thing. Obviously, when you go in the algorithm of DVT, provoke and unprovoked DVT, that's a different story. Now, coming below this, so other than pulmonary embolism, it is related to heart, so we'll discuss some conditions of the heart, also cardiac status. So most common is your MI, acute MI. So in acute MI, first your patient will present with typical chest pain, atypical chest pain, and you suspect that this could be an MI. So first thing you need to ask for the window period, when this is started, because if it is a window period, then the treatment is thrombolysis and something else which you can do. But when you do an ECG, immediately you should pick whether it's an STEMI, ST segment elevation MI, or it's a non-ST segment elevation MI, because the management differs. In ST segment elevation MI, you need to reperfuse the patient either by thrombolysis or by angiography or angioplasty, PCI, percutaneous coronary intervention. So in ST segment elevation MI, you can see that ST is elevated. Now, at times it may happen that ST is depressed in all the leads, but AVR is upright. So this is also an STEMI, because the lesion is very proximal. New onset LBBB, if you don't have a previous ECG, but you are seeing this is an LBBB and the patient presents with chest pain, it is a candidate for thrombolysis. Posterior circulation, posterior wall MI. So it will have, in anterior leads, it will have a ST segment depression, but it's actually ST segment elevation in the posterior leads. So it's also category of STEMI. So whenever you see an ECG of a patient presenting with chest pain, always try to look whether it's a ST segment elevation or non-ST segment, because in STEMI, you need to perfuse the patient either by thrombolysis or by percutaneous coronary intervention. So this is important. Then after one more thing, while examining this patient, always check for all four limbs, the pulses in all four limbs, because one of the differentials is aortic dissection. In aortic dissection, the thrombolysis is contraindicated, it can be catastrophic. To check the pulses in all four limbs, if there is a delay or something, inequality, similarity, it is always better to rule out by the different modalities. Now, once you have thrombolized or you have reperfused the patient, once you have thrombolized the patient by any fibrinolytic agent, if the PCI is not available or not feasible, so after 60 to 90 minutes, do a ECG, repeat an ECG. In the ECG, if the ST segment which were elevated have dropped down more than 50%, that means it was a successful thrombolysis. But if it is not a successful thrombolysis, ST segments are elevated or more than 50% still elevated, then you need to do a PCI in such patients, and it will be called as a rescue PCI. So don't wait for it. After 60 to 90 minutes, you do an ECG. If the ST segments has not settled more than 50%, you can always call a cardiologist or your team that we need to do a rescue PCI for such patient. Chest pain, ongoing chest pain is not a very good marker, because chest pain can go away in two conditions. Either the vessel is perfused or the myocardium has got damage. So dying myocardium can give pain, but if the myocardium has been damaged, it will not give pain. So don't rely on this. It's a one good clinical marker, but do an ECG and look for it. So Dr. Abhi and Dr. Benjamin are sitting at the back of this session. So they are prompting, giving me signals if I'm missing something. So you may feel that there are some voices from the behind. Now, arrhythmias. So in cardiac, now you see arrhythmias. So usual common arrhythmias, one of the deadliest is VT. So in VT also monomorphic VT or multifocal DT. Multifocal is your torsades. So treatment is shock. You need to shock the patient and give magnesium sulfate. That is important. In VT also, monomorphic VT, stable or unstable. In fact, in any arrhythmia, whether it's atrial fibrillation or AF or anything, you need to see whether the patient is hemodynamically unstable or unstable. If any arrhythmia which is causing hemodynamic instability, you need to give shock and revert that. If it is hemodynamic stable, then based on the duration of the arrhythmia, you can take decision pharmacological versus defibrillation or shock rhythm. Now, when your patient is hemodynamically unstable, you have shocked the patient. But if the patient is hemodynamically stable, then you need to revert it, either control the rate or control the rhythm, manage the rhythm. So in this condition, the time of onset of the arrhythmia is very important, whether it was within 48 hours or more than 48 hours. Because whenever the heart beats in an arrhythmia, there is a stagnation of blood flow into the left ventricle or both the ventricles, and that causes clot formation. So if it is less than 48 hours, the onset of arrhythmia, we may feel that it is presumed that there will be no clot in the LV, and once you restore the rhythm, this clot will not get in the blood vessel. It will cause no stroke or any bowel ischemia sort of. So within 48 hours arrhythmia, you can give low molecular any anticoagulation and you can revert the rhythm. But if it is more than 48 hours, then you need to do an echo and you need to find out whether there is a clot, then properly heparinize the patient, and then on a particular date you need to cardiovert that patient. So duration of arrhythmia, since when it started, whether it was started 48 hours before or 48 has been passed, this is very, very important. Also hemodynamically stability, unstable. In unstable, you have no choice. You need to give all the anticoagulants and you need to cardiovert. But in stable patient, you have a choice. So this is very, very important. The reason is because more than 48 hours, there can be risk of clot formation, and this can embolize once you rhythm is restored, and clot can go anywhere, stroke, bowel ischemia, limbs, anywhere. That's the thing. Now we have discussed in MI that you check all 4 limbs for aortic dissection. So in aortic, suppose it turns out to be aortic dissection. So aortic dissection is of 2 types, Stanford type A and Stanford type B. A means it is in the arch of aorta, it is involving the root, and it can involve the coronae in the ascending aorta. And B means it's in the descending aorta. Important is A needs surgical intervention. The B type may or may not need surgical intervention. So what should be our goals before giving the patient to the surgery? So in Stanford type A dissection, if it is involving the ascending heart, we should control the rate and we should control the BP, so that your aortic dissection doesn't get propagated more. We need to slow down the propagation as far as possible. So you have labetalol and you have other antihypertensives. So you control the rate somewhere around 60, BP somewhere around 110, 120, so that you can go and read. But the important is you need to control the heart rate and BP in aortic dissection, so that the propagation of dissection is reduced and the patient can be managed till the patient can be sent to surgery. And in type B, where there is a thoracic aorta is involved, ascending is not involved, it depends on case to case basis whether we need surgical intervention or not. So in aortic dissection, target your heart rate and blood pressure. It is very, very important, because if the blood pressure is too high, the dissection will propagate and it can be very catastrophic. So this is one. Now in relation to MI, arrhythmia, and we have one more condition which is called acute decompensated heart failure. So again, whenever a patient is having respiratory distress due to decompensated heart failure, obviously first you need to look whether it's an acute onset decompensated or it was a chronic one, DCMP, and now it again propagated. So again, the treatment will depend whether it's because of MI or because of previously mismanaged drugs and patient activity. So again, like in asthma and COPD, we have discussed that on an IV and with diuretics, whether the patient is getting fatigue or not fatigue. Patient is being managed on an IV or non-IV. So if the patient becoming drowsy or patient is not retaining CO2 or the patient is in shock which is not manageable, you need to intubate electively. But in CCF patients, NIV works very well. This is one of the few indications of clear-cut BiPAP support on NIV. So just look for fatigability of this patient and always try to find out the cause why this CCF has happened. Whether drugs patient was not taking or the drugs are not optimized, or even if it is an old one, old heart failure, whether this is an acute onset MI or acute onset arrhythmia which has caused this CCF. So these are the things you need to look in CCF. Okay. Now one more condition related to heart is your post-valvular heart replacement patients. I think anyone who is dealing with these post-valvular heart replacement patient, if they come with dyspnea, so suppose there is a mitral valve replacement, a aortic valve replacement, now the patient present with dyspnea, other than ruling out all the causes, always keep in mind whether we are dealing with a stuck valve or not. Because if the valve gets stuck, there will be no forward flow, there will be shock to the patient, there will be frank pulmonary edema and dyspnea. So always do an echo and try to figure out whether we are dealing with a stuck valve, because you need to thrombolize such patients. So this is very important because they respond very drastically and you can save the life of patient. So put an stetho on the chest. Look whether you are able to hear. If it's a metallic one, you will be able to hear the click or not click. Always inquire which type of valve that got replaced. Put in a stetho, do an echo, but keep your stuck valve differential in the diagnosis, whether we are dealing with stuck valve. And also, a valvular heart patient presents with drowsiness. Always check the coagulation profile, because these patients remain there for anticoagulants and they can bleed. So if the INR it got deranged, they can have bleed. So any patient who present with valvular heart disease dullness, get a CT scan done, rule out intracranial bleed. You may find hyponatremia or something like that, but always it's always better to get a CT scan done in such patients. Now, the other related one which I think in this cardiac topic remaining is hypertensive emergencies. So hypertensive emergencies are two types. One is hypertensive urgency and one is hypertensive emergency. There is a difference. So whenever patient present with blood pressure 220, 110 or like then whatever the cause, always look for whether there is a sign of target organ damage. So target organ damage can be patient is having headache, encephalopathy, or the patient can be, if the heart is involved, the patient can be having chest pain, heaviness. Or if the kidneys are involved, the patient will have low urine output or oliguria is developed, raised creatinine is developed. So if there is a raised blood pressure with target organ damage, it's an hypertensive emergency. It needs to be tackled with IV drugs and a patient should be admitted. If it is simply a rise in blood pressure, you can keep in the ER, give oral medication, means simply the patient feels something is uncomfortable and you find out that there is a heaviness, sort of generalized weakness, and then you find out BP is 220 versus, so you can give oral medication also. But remember, whether it's an hypertensive emergency or hypertensive urgency, don't bring down the blood pressure too fast down. It's 25%, something 20-25% within first hour. The reason being, if we drastically reduce the blood pressure, like it's 220, you think now 140 should be there, it will cause hypoperfusion sort of picture in the brain, and then we can have other complication also. So if it is 220, 25%, somewhere around 190 is fine within our, then gradually decrease it. So whenever this patient comes, first think whether it's a hypertensive urgency or hypertensive emergency in which there is a target organ damage. Plus, if we want to reduce the blood pressure, we can reduce the blood pressure slowly. Okay, so this completes your grossly the cardiac clinical picture, cardiac conditions which are. Next, we will discuss, before moving to another system, we'll discuss the endocrine part. In endocrine part, we have mostly diabetic ketoacidosis and hyposmolar non-ketotic coma. So first, let us understand these two. In both the condition, the problem is the diabetic patients, there is a relatively shortage of insulin. So the body requirement of insulin is high, but the body is not able to make it. So when insulin is not able to utilize the glucose, when the body start utilizing your proteins and adipose tissue, they convert into ketones, and the ketones rise in the body, and you develop patient develop ketoacidosis. While in HONC the sugars are high, there is subtle amount of insulin deficiency, but the ketoacidosis will not be there. So in DK, don't just start insulin. They are usually dehydrated. First, you need to find out what was the cause of DK. Usually, it's an UTI or infection sort of, which precipitates DK. So, firstly, the treatment the treatment protocol for DK is threefold. One is fluid. Second is most important is your potassium level. So, check for the potassium, because as soon as you start in the third phase insulin, what happens? Insulin will cause potassium shift from intravascular compartment to the intercellular compartment, and the patient can develop hypokalemia. So the treatment is, first you give fluids, then do a blood gas, see for the acidosis, check for the potassium. If the potassium is 3.3 or less than 3.3, don't start insulin immediately. Correct it, supplement it, and then start. You can supplement and then start insulin. Even giving fluid, lot of fluid initially can help you decrease the ketoacidosis for that part. When will this treatment will stop? Once all the ketones has been out from the body. How will you check it? You should do a blood gas and see whether there is no HAGMA in it. NAGMA can develop because of fluid, but there is no high anion gap metabolic acidosis in the ABG. Now, most of the students, what they check is the urine ketones. It's a good thing. But the problem is there are two types of ketones in the body: beta hydroxy state, beta hydroxybutyrate, and ester. So your beta hydroxybutyrate is the one of the most common thing which is rise in DK, but your urine stream picks the acetic acid. So it may happen that the patient is having ketones body because of the beta hydroxybutyric acid, but the urine strip is not picking up because of the acetone, or the beta hydroxybutyric acid levels are little bit down. So it turned out that urine ketone are negative. So it may happen you feel that it gets corrected. No, do a blood gas, see for the HAGMA. If it is HAGMA is resolved, the DK is resolved. Till that time you need to manage on the DK protocol. So fluid and potassium is very, very important. So, and thirdly, don't give too much soda bicarb in DK. Even they say when the pH is 7 or 6.9, don't give bicarb in such patient. They respond very well to hydration, potassium, and insulin. In HONC, hyperosmolar non-ketotic coma, it's non-ketotic. You just hydrate such patient. They are more dehydrated. Supplement potassium and insulin. That's the role. And patients are usually drowsy and neurologically down. So the target in HONC is your neurology. The patient now responding, became conscious, that is your end target goal. So this is thing. In DK, very, very important. Again, potassium is one thing which you need to be aware of. Now we come to renal part. So in renal, AKI and renal replacement therapy. So CKD patients, CKD patients are already there. So we present in ICU either acute kidney injury or acute and chronic kidney disease. So one very, very important thing is you always try to find out what is the cause of acute kidney injury. Whether it's a pre-renal cause, whether it's a renal cause, or whether it's a post-renal cause. Pre-renal cause means hypovolemia, hypoperfusion. Renal cause, contrast-induced nephropathy or pyelonephritis or something like. Post-renal cause, there is obstruction, renal stones or some obstruction like that. So what you need to do, get an USG done. In USG, ultrasonography, you will be able to find from the echo texture whether it's an AKI picture or there is a renal cause or whether it's a post-operative cause, and you can handle it accordingly. Secondly, creatinine is not the criteria for dialysis in the ICU per se. Creatinine is doing not much harm to the patient. It's just giving you information that the kidneys are not working properly. So there is no creatinine value in which you can straight away jump and say that now a patient to be dialysis. It may happen that on high creatinine also the patient may not require dialysis, but it may happen that on low creatinine also the patient is at the verge of getting dialysis. So what are those indications? We have told in the previous video also. But if you, for easy to remember, A, E, I, O, U, by the vowels you can remember. If it is a refractory acidosis, or refractory hyperkalemia, or there is intoxication, or there is signs of pulmonary edema, fluid overload, or patient is becoming uremic, throwing seizures. So these are the indication for which you will dialyze the patient. So once you have started decided dialysing, what are the types of renal replacement therapy? There are only mostly to three part: intermittent hemodialysis, SLED low efficacy dialysis, and your CRRT. So all are three the same. They differ in two things. One, the duration. The intermittent hemodialysis finished in 3 to 4 hours. Your SLED in 6 to 8 hours, and CRRT is a 24-hour issue. Means, yeah. But remember, the slower the dialysis, the slower is the rate of clearance of the solute. So intermittent hemodialysis can clear your urea and potassium very fast, while your this CRRT and SLED will clear them slowly. That's why. But the good part is this slow dialysis can handle the patient's dialysis hemodynamically unstable patient. While if the BP is low, this intermittent hemodialysis can't handle it. So you need CRRT and intermittent SLED for those matter. So hemodynamically unstable patient, SLED or CRRT. Hemodynamically stable patient, intermittent hemodialysis. Very high solute load or very high life-threatening hyperkalemia, choice is intermittent hemodialysis, but if not, then you can extend it for certain duration. So these are the things you should always look for. Always try to find out what is the cause of this renal replacement, what is the cause of AKI. Also, one thing which is missed by many, even the experienced one, even we at times are very cautious about it. Whenever a patient is developing AKI, you should go through a drug chart, adjust the doses of the drugs, antibiotics, other things according to creatinine clearance, not just on the basis of creatinine. Do a creatinine estimated GFR formula. Try to figure out, suppose a lady is of 30-40 kg and 92 age. Her creatinine clearance will be different than a healthy 60 kg person with a good weight. So that is the thing you should remember. Also, exclude certain drugs which can cause AKI, like statins or ACE inhibitors. Some patient is hypertension taking. So many drugs are there which can cause AKI and aggravate the AKI. You review a drug chart and try to avoid which are not very much necessary at this stage. Now, after the kidney, very good friend of the kidney is your liver, because it gets affected or it affects the kidney when something goes wrong. So with that we come to GI part. So in GI part, you have acute liver failure due to any cause, whether hepatitis A, hepatitis E, or any other poisoning, whether there is an acute or paracetamol overdose. For any reason, if there is a patient is presented with acute liver failure, so acute liver will present with raised enzymes, patient present with encephalopathy, raised ammonia, and renal failure, a lot of things. But the only investigation which is very, very important for you is your prothrombin time. If prothrombin time is increasing, that is a sign that liver is failing. If the prothrombin time is normal, that you are assured that we are in a safer zone and this liver will recover. So keep a watch on prothrombin time daily, if not 12 hourly. And if prothrombin time is increasing in acute liver failure, that means your liver is failing very fast. And if your PT is improving, prothrombin time is improving, the other report will follow. The patient will improve. But the common mistake is whenever prothrombin time reaches 23, 30, 35, it's a reflex that we supplement it plasma or fresh frozen plasma coagulation factor to correct the PT. Don't do that unless there is an active sign of bleeding or there is a life-threatening condition, because prothrombin time will get altered because of the FFP plasma. It's the only indicator which will tell you whether your liver is failing or not. So if the patient is stable, but just because prothrombin time is rising, just for the correction per se of prothrombin time, don't give FFP. This is one thing you should remember in acute liver failure. The only investigation which is very, very important is your prothrombin time. Then in chronic liver failure, like acute and chronic liver failure, like Patient may present with cirrhotic patient due to any cause and now presented with decompensated liver failure. So always try to figure out why this liver has decompensated acutely. One of the most common causes is infection, and infection is SBP, spontaneous bacterial peritonitis, one of the causes. So always try to confirm that diagnosis, try to cover it with antibiotics on day one for that matter, and look for the cause, what has got down your liver in chronic patients. So SBP is something which you need to be always keep in mind. Again, prothrombin time should be monitored. If prothrombin time is rising very high, that means this patient is very critical. Now in GI, the other condition which the patient present is your GI bleeds, upper GI bleed or lower GI bleed. So patient will present with hematemesis and patient with melena like sort of condition. So obviously you will look for ABC, airway breathing circulation. If the patient is having tachycardia and hypotension, that means so much blood has been lost like that, and you will manage it obviously by upper GI endoscopy, colonoscopy. That is different story. But initially try to find out what is the cause of upper GI bleed, whether it is an ulcerative bleed or whether it's a variceal bleed. Like in chronic liver failure, the patient may have varices and they may have ruptured and bleeding, while the patient is on NSAIDs for any other cause and taking antiplatelets and now has bled due to ulcer. So on history basis, try to figure out these things. Why it is important? Because the treatment differs. For one, you give pantoprazole infusion for your ulcerative bleeds, while terlipressin sort of medications you need for variceal bleed. So if in doubt, what we suggest, you can start with pantoprazole stat and infusion, and you can give stat dose of your terlipressin. By the time upper GI endoscopy and other intervention can take place. But you should keep in mind that what is the cause of upper GI bleed or lower GI bleed in such patients. So this is very, very important. Now one more GI condition is acute pancreatitis. Very important condition, very painful condition, and it is a lifelong morbidity for the patient if it can get converted to severe one. The only intervention which is helpful in pancreatitis in reducing the severity is your hydration within first 24 to 48 hours. So in first 24 to 48 hours from the start of the symptom, hydrate the patient well. Even at the cost of some edema or some sort of condition, give liberal amount of fluid which is recommended in the guidelines. Give lot of fluid to this patient, 200 ml, 300 ml per hour, giving boluses. If proper hydration is given to such patient of acute pancreatitis in first 24 to 40 hours, we can markedly reduce the severity of the disease from at least severe to moderate or moderate to mild. This is going to be help, because after that giving lot of fluid will not help. So giving lot of fluid in acute pancreatitis in the initial hours is very, very important. Secondly, lipase is not a test which will tell you about the severity of the disease. Lipase is just there more than 3 times to help you in making the diagnosis, but it has got no role in prognostication. Even if lipase of 200 can have a severe pancreatitis, even if a lipase of 2000 can have a mild pancreatitis. Not useful monitoring. What you should monitor is your CRP levels. If the CRP levels is rising high, more than 40, 45, that means this patient is landing into severe pancreatitis. You should get in day 1. So in pancreatitis, fluids and CRP, these are the 2 very, very important points which you need to remember. Now, once we have reached that, also in pancreatitis, as you rightly pointed out, nutrition is very, very important. There is a misconception that to give the pancreas a rest, we should not feed the patient orally. We should start DPN or something like that. But no, the current guidelines say that you should, if the patient is not vomiting and able to tolerate, you should give enteral feed. Whether start with oral liquids, or if not tolerate, you can start with RT feeds also. It will help in a long way in improving the patient from this disease. So from nutrition point of view, altered nutrition is preferred. So now coming to infection part. Infection is something which is a very broad terminology and it covers different sorts of infection. So I'll give you a small bit of information regarding sepsis. First thing, you need to understand that not every infection is sepsis. there is a difference between infection and sepsis. What happens in infection? What is happening? There is a bug and your body is trying to fight with the infection. The immune system is helping you out to fight with the system. While in sepsis, what happens? The immune system get maladapted and try it. Other than fighting the bug, it becomes harmful to your body. Also, it becomes maladaptive. It gets overshoot. This sort of definition is there. You can read. So in sepsis, your body immunity is not helping you out. It is get maladapted. And it's not in your fever. So that is sepsis. In sepsis, once you identify the patient that this patient is sepsis, whether it is sepsis or septic shock, only two things now there. Whether the patient is hemodynamically unstable in spite of correction of by fluids and vasopressors, or patient is stable, means in terms of hemodynamics. So one thing. Second thing, whenever you feel that this patient is sepsis, always try to find out what is the cause. From where the source is it, whether it's in the lungs, in the heart, or in the urine, or it's in the bowel, or it's a brain, or somewhere else, or it's a cellulitis. Unless you take care of the source, patient is not going to improve. So try to figure out where is the source. Now, once you identified the source, whether this can be surgically treated or surgically debrided, or whether we need to do it systematically only antibiotics. So because if it is surgical like gluteal abscess, it needs to be debrided, and then you need to add the antibiotics according to the condition, whether this antibiotic will be helpful for this particular condition, whether it will penetrate there or not. So type of antibiotic choice will depend upon the source. Also, the type of antibiotic will depend whether this patient has received previously antibiotics or not in some other hospital, or previously taking some antibiotics, or same antibiotics has been given to this patient for same condition before also. So in sepsis, important is whether the patient is in shock or not shock, because septic shock patient have a 40% more mortality. Second, identify the source, if it can be surgically treated or reduced or not reduced. Secondly, the type of antibiotic. And then obviously you need to take the blood culture as soon as possible and give the antibiotics. So these are the few things you need to take care in the sepsis. For different specific type of sepsis, we can have another discussion, but these are the general principles. But one very important infection I want to mention out, that if you are suspecting this patient is having CNS infection, whether it's a CSF meningitis or CSF encephalitis like that, it's mandatory to give antibiotics as soon as possible. Don't wait for your CSF or cultures to come out. Give antibiotic, because it's the only condition where you don't wait for your culture and CSF to be done. If you are suspecting this patient is having fever, altered behavior, neck rigidity is there, straight away give the antibiotics, and you can then take cultures and do the CSF. So CNS infection is an emergency which needs to be handled, and appropriate antibiotics should be given. Now, once we have discussed regarding the CNS, so we'll cover up the CNS in next few minutes. The most common condition, one of the common condition is stroke. So in stroke means, if you see a patient of stroke, inquire first what is the time of onset, whether this patient is window period 3 hours or 4.5 hours, because you can thrombolize such patients. Then obviously we'll see the scale or everything. So whenever stroke patient comes, look for time of onset, whether when the symptoms started, whether it's a wake up stroke, means patient was seen normal in the night but wake up with some symptoms. So in that category, you don't find it difficult to find out the time of onset. So you will consider time when seen normal. Nowadays, we can do a perfusion scan and see the penumbra, and it will be able to identify CT perfusion scan whether this is a recent onset or not. But for clinical matter, always try to figure out what was the time of onset. Now, once you've identified that time of onset, take care of ABC, obviously, get a CT scan done. So if your patient is stroke and CT scan normal, then it's a good candidate to thrombolize such patient. Obviously, then certain targets to be maintained, blood pressure target, sugars to be maintained, history needs to be taken. But window period, time of onset, get a CT scan done. These two are very important. Now, once you have thrombolized this patient, Now, monitoring GCS is very, very important. Any drop in the GCS of more than 2 is an indication that this patient needs to get urgent CT scan again. Because what will happen, patient can have bleeding in the brain, so you need an urgent CT scan. So in stroke patients, you need to focus on time of onset, get a CT scan done, look for the ABC, then post thrombolysis, what fall in the GCS should be monitored, and then immediately CT scan should be. So once ER will say that we have thrombolized the patient, we are shifting in the ICU. So in ICU, you need to monitor the GCS, keep a watch on blood pressures, like that. So these are the things which you need to remember in stroke. Secondly, one thing which I forgot to mention, I have been prompted from behind, that in stroke patients, always check the blood sugar. So whenever your patient comes with a stroke thing, always check the RBS, always check the sugar, that because it is one of the most common mix of stroke patient. A patient may have sugar levels of 45 or 50 and it feels like that this is presenting with a stroke. So always check the sugar level of a patient in which you are suspecting a stroke. So this is very, very important. Thank you to Abhi and Benjamin. Then because we are discussing stroke, we can ischemic stroke, we will discuss the IC bleed also, intracranial bleed. So again, when a patient present with intracranial bleed, you need to again follow the ABC, get a CT scan done and things. So, but when you do a CT scan brain done, you at your resident level should be able to identify whether this patient needs surgery or this patient can be managed conservatively. This is very, very important, because what is expected from seeing the scan, nowadays you can WhatsApp the scan, or by your hospital technology they can get transferred to different consultant, but at your level you should be able to understand whether there is a midline shift, whether there is a very large edema, this patient needs to be taken for surgery, craniotomy early as possible. So in intracranial bleed, always look at the scan and decide whether this patient needs a surgical intervention or not. It may happen there is a mild midline shift, but this may patient develop this surgical condition later on. So on that way, you will counsel the relatives. Always check for the ABC, intubate timely, and pupillary signs. Early dilatation, or even if not dilating, if the reaction begins sluggish, suppose there is a left intracranial bleed and the pupil started becoming sluggish, it was normal, but now what is happening, it's slightly becoming unequal and slightly becoming sluggish reacting, not fixed. It's a sign that this patient is developing raised ICP. We need to intervene, we need to give anti measures, get a CT scan done, and you can then do surgical intervention as well. So in intracranial bleed and both ischemic stroke, one thing needs to be done is don't too much lower the BP, go by the guidelines. There is a habit of decreasing BP to 110, 120. No, raised blood pressure is a body's protective sign to perfuse the brain, which is there near the penumbra. So don't too much lower the BP. There are specific targets mentioned in stroke patients and intracranial bleed patients. So target the blood pressure according to that also. Now, one more thing. On the scan in intracranial bleed, most of them are because of hypertensive bleed near the basal ganglia or like that. But if we see bleed in some other particular condition, always think of EV malformation sort of picture. So if creatinine is normal, get an CT angio done to look for the vessels, whether there is any EV malformation is there or not, if there is an unusual location of the bleed. Now, because we have discussed this, we should also talk about SA, subarachnoid hemorrhage. So subarachnoid hemorrhage, very important. Try to get CT angio done in subarachnoid hemorrhage, because 85% of the time it is due to aneurysmal bleed. And if it is an aneurysmal bleed, this has to be done a definitive treatment, whether it's via clipping or coiling needs to be done, because until unless definitive treatment is done, there is chance of rebleed in such patient, which can be having a very high mortality. So in SA subarachnoid hemorrhage patients, get a CT angio done, consulting your neurologist after creatinine and other levels, but always check the blood vessels. Also, in maintaining blood pressure and other things are important as such, but there is a drug called nimodipine which is there to prevent the vasospasm. Don't hold the nimodipine just for the sake that it will cause a fall in the blood pressure. It is usually brain specific and it will not cause too much fall in the blood pressure. You can always maintain the blood pressure by hydration and some vasopressor support, but keep nimodipine running so that your chances of vasospasm are reduced in the brain. This is very, very important. Now, because we have discussed SAH, so we can cover up traumatic brain injury also here. So in traumatic brain injury also, when a patient comes, again there is a trauma in the brain, signs of raised IP taken care of. But in traumatic brain injury, always take care of the spine, C-spine. C-spine is something which needs to, by default, any trauma patient, you put in a Philadelphia collar. Afterwards, you will do a CT scan brain and then cervical spine screening sort of thing, and you will rule out whether the spine is okay or not. But any trauma patient who comes with head injury, you put a cervical collar. This is very, very important because if not taken care of, it can then damage, do further damage to the patients. And then taking care of the airway and pupillary sign. These are the routine things which needs to taken care of. Then in trauma, there can be SDH, contusion, and EDH also. So difference between EDH and SDH should be understood. That's why you will be more vigilant. SDH is subdural hemorrhage, which is a venous blood, and EDH is extradural hemorrhage, which is an arterial blood. So EDH patient deteriorate very fast. It may happen the patient was drowsy, there is a lucid interval, patient becomes normal and then suddenly drops. So even if it is a very small EDH, extradural hemorrhage, the patient needs to monitor very meticulously with all the blood arrange and FFP arrange and surgical consultation on call, because this patient can deteriorate very fast. It may not happen, that is a different story, but EDH patient needs to be taken care of. Very, very, very important. Because we have discussed trauma, one more thing which I would like to tell you, always check the abdomen in trauma patient. Always put a your hand on the abdomen, see whether there is a tense or soft, and do an USG to look for the subtle injuries, because it may happen that the patient may have blunt abdominal trauma and then the patient can develop massive shock and deteriorate very fast, and we never know what had happened. So in trauma patient, always get an USG done, always look for the blunt abdominal trauma injuries, because these patients can deteriorate very fast. So this is something which needs to be taken care of. Now, because we have discussed the cervical spine, so in cervical spine, what is important is whether it's a complete transaction or it's just a contusion or there is no injury. So in complete transaction and no injury, that is different story. But if there is a contusion, there is some role of steroids in the early stages. Earlier it was 8 hours from the time of onset of injury, but now it is reduced to 3 hours. So if patient comes within 3 hours, if you give steroids to such patient, it may help in reducing the cord edema and further damage. There are different guidelines. This is always a controversial topic, but you need to understand that if it's a contusion or swelling in the spinal cord, if it presents early, steroid may have certain role. Also in trauma patient, tranexamic acid has got a good motility benefit. So for preventing, in trauma and contusion patient, we can give tranexamic acid bolus followed by infusions. This has shown very good results. So these are the things you need to take care of. Now, other two more neurological condition is, one is your status epilepticus, that a patient present with seizures and something. So always try to find out what is the cause, whether it's a drug defaulter or change in the medications, or there's a new onset or some other cause has precipitated status epilepticus. So obviously you will start with giving, always sugars needs to be checked in any neuro patient from the starting. If it is normal, you give an anti-epileptic, then the seizure is not getting control, you would increase the dose or give the anti-epileptic. Even if it is not taken care of, then you need to then ventilate the patient, taken care of airway, and give infusions by benzodiazepines or thiopentol, other drugs you need to. The important thing is, don't use muscle relaxant in such patients, because they will what you call from outside you will not see any seizures in this patient. So try to control it only by sedation, whether it's benzodiazepine, fentanyl, propofol, thiopentol, or the other, but don't give muscle relaxant to any patient on the seizure. If your hospital is having EEG, get an EEG done with continuous monitoring, and you will be able to see whether there is a activity, electrical discharge or convulsive activity in the brain or not. That is something needs to be taken care of. So in status epilepticus, one drug, sugars, then one drug, two drug, raise to your maximum doses, not getting control, take care of the airway, and then continuous infusion drugs to be given, no muscle relaxant, and EEG. These are the things needs to be taken care of. Now, one more condition which is there is neuromuscular disorder. Neuromuscular disorder like Guillain-Barré syndrome, myasthenia crisis, motor neuron disease. So in this everything is fine. The only thing is muscular weakness. So muscle weakness is there. So what we are concerned in the ICU is regarding the chest respiratory muscle weakness. If the respiratory muscle weakness is there, the patient will land in respiratory arrest. Patient can land it. So how will monitor? You will monitor one obviously by the respiratory which you are seeing. There will be shallow breathing and single breath count. Single breath count is one of the good clinical indicator which you ask the patient to take a deep breath and then say the 1, 2, 3, 4, 5 like that, and you document it. He or she was able to do up to 20, 25, 30 like that. Below 15, if it is there, then it's alarming. Then you give support by NIV, but NIV doesn't help much because ultimately NIV relies on your muscles, respiratory muscles. So if single breath count is decreasing, the breathing is shallow, and if you do an ABG, then if your PCOT is normal or increasing, even normal is not good. So if your PCO2 is high in such patient, that these patient needs to be electively ventilated till the time their muscle power improves or crisis gets resolved. So this is very, very important to monitor in any neuromuscular patient: respiratory muscle fatigue, rising PCO2, single breath count. Now, one more thing, okay? One more thing, who patient who present with neuromuscular disorder like picture like myasthenia, GBS or something, always check for the potassium levels in such patient, because potassium is something which can mimic this paralysis sort of picture. We recently have a patient yesterday only, potassium of 2.2. So once you correct that hypokalemia, the patient also look for CPK total in such patients. So check for the potassium in neuromuscular disorder like picture patients and CPK total also. But potassium is very, very important, which needs to be taken care. If it gets corrected, patient drastically improves. Post-op care is a very wide topic, but taking care of the vitals in neuro patient, pupillary signs, in maintaining the physiology is very, very important. But one thing I like to tell in regarding the urine output, if it is the urine output is somewhere around 1 ml per kg per hour, though we need to maintain it is more than 0.5 ml per kg per hour, that is fine. But if it is dropping, this is early sign that whatever physiology is going on with the patient is not correct, and we need to take care, whether it's bradycardia, tachycardia, hypertension, that all things. But if your urine is good, that is pretty sure that most of the parameters are going in good direction. In neuro patient, polyuria is also difficult. If the patient develops polyuria more than 300-400 ml per hour, that this patient may land in diabetic insipidus. So very high urine and very low urine. So this is something in post-op patient, urine is something which you need to be very much focused on. This is because if it is not coming, that means something is wrong with other physiologies also, like that. Poisoning, I would like to give you one tip regarding the poisoning. There are certain conditions in which lavage needs to be done and certain conditions in which lavage needs not to be done, where Ryle's tube or nasogastric tube should not be inserted. So in poisoning, you need to remember in which condition the NG tube is contraindicated. One of them is hydrocarbons, like that picture, or acid ingestion. In these, don't put an NG tube because they can harm the patient. Also in sulfase poisoning or aluminum phosphide poisoning, saline lavage is not indicated because it get combined with the aluminum phosphide and then phosgene gas will be formed and this can harm. So do a lavage with coconut oil and potassium permanganate, which is there in the recent literature. So in sulfase poisoning or aluminum phosphide, no saline lavage, and in certain condition where NG tube should not be inserted, this has to be kept in mind. Now, one gynae condition, obstetric condition is preeclampsia. So preeclampsia is something which the patient present, and you need to vigilant regarding whether the definitive treatment of preeclampsia. And difference between preeclampsia and eclampsia is eclampsia means the patient has thrown seizures, and preeclampsia means patient is prone to throw seizures. The definitive treatment is termination of pregnancy by elective cesarean section, like that, or routine normal delivery. That is, it depends upon the condition of the patient. But for seizure, you can give magnesium magnesium. You can give for edema. You can give diuretics. BP needs to maintained. What antihypertensive you need to give? You give labetalol, hydralazine, centrally acting drugs, like that. And important thing is get an USG done for such patients, because the reason is abruptio placenta also is one of the differential. If the patient has raised blood pressure, or there is a slight bleeding, so abruptio placenta can be very catastrophic in the OT. So get an USG done and rule out abruptio placenta in such patients. So I think we have tried to cover maximum things, maximum clinical condition in this short video. I again thank to Dr. Benjamin and Dr. Abhi, who are the members of the academic committee of EHB ICM, who came up with this idea. If you have any condition for which we can add on this, you can post in the comment section, and see you in the next video. Thank you.